Good evening, everybody. I'm Dr. Horia from the University Hospital of Bucharest Cardiovascular Clinic. I would have pleasure in presenting you the surgical anatomy of the aortic root. The aortic root depicts an apparently simple structure with finely tuned elements that accomplish complex functions. But are the pulmonary and the aortic roots simpler structures as compared with the atrioventricular valves, for example, which possess a subvalvular apparatus? First of all, it is important to underscore the particular position of the aortic root, which is wedged between the remainder cardiac elements and with which it establishes anatomical relationships, the left and the right atrium and their appendages, the mitral and the tricuspid valves, the pulmonary trunk, the fibrous trigems of the heart. Not least, the two coronary arteries originate from the aortic root. The general disposition of the aortic root is with a dilated portion, represented by the sinuses, between two narrower segments, the left ventricular outflow tract and the ascending aorta. This allows the formation of eddy currents in the sinuses and the systolic dilation of the sinuses. The aortic leaflets will flutter without making contact with the aortic walls and without obstructing the coronary ostia, while being also ready to close during diastole. The mechanism of vortex formation may be due to the shear forces of adage and forward flow and/or induced by the impact with the sinotubular junction. Traditionally, various landmarks are described at the levels of the aortic root, but the only really apparent are the crenated insertion of the valve leaflets and the sinotubular junction. The numerous annuluses are more apparent at the level of the pulmonary root, where the leaflets take off from a sleeve of freestanding musculature, and only the muscular portion of the aortic root, which corresponds to the left and the right sinuses. The fibrous portion of the aortic root, occupying roughly 1/3 of the circumference, skirts between the left and the right trigems of the heart and continues with the mitral aortic curtain. Note also the non-planar disposition of the distal interventricular septum. The anterior mitral leaflet alternatively delimitates the inflow from the outflow compartments of the left ventricle and consequently takes part in the makeup and function of the aortic root too. The fibrous portion of the aortic root corresponds to the two fibrous trigems of the heart and is related to the left and the non-facing sinuses of the aorta. Enlargement procedures such as Nix and Manuguyan are performed at this level. These allow, however, limited enlargements, but have the advantage of not interfering with the vascularization of the aortic root. Although symmetrical, the aortic root, also apparently symmetrical, the aortic root depicts a natural asymmetry. The volumes and the distensibility of the sinuses are different. This generates an aortic tilt angle, which in some species is greater than in men. The tilt angle probably contributes to the reduction of leaflet stress. The resultant interleaflet triangles are also asymmetric and are not isocels. The entire aortic root complex dilates not only circumferentially, but also longitudinally. The non-uniform deformation at the level of the basal ring becomes uniform distally at the level of the commissures. The aortic root absorbs and evens the non-uniform distensibility and the torsional movements of the base of the heart. This is reflected in disease when one or more of the elements constituting the aortic root are damaged. With the dilation of the sinotubular junction, the stress on the leaflets is minimally augmented, while with annular ectasia, dramatically increased this stress, leading to damage of the leaflets. Hence, surgery must be considered at earlier stages in patients associating root dilation plus annular ectasia. The aorta is a complex organ with segments that have different embryological origin and with different structure. The elastic elements and the vasa vasorum decrease towards the abdominal aorta. Moreover, the various segments of the aorta bear different types of pressure and stresses. The aortic root and the proximal aorta must stand the systolic distension, the jet impact, the to and fro movement of the cardiac base, the angulation and deangulation of the ascending aorta, while the arch is relatively fixed by collaterals, the ligamentum arteriosum, and the pericardial ligaments. The aortic root distends during diastole, but the aortic wall is not completely relaxed in any phase of the cardiac cycle. It is most important to be aware of the various measurements of the aortic root. The general parameters can be quantified, and these are the basal ring, the sinuses, the sinotubular junction, and the ascending aorta. To these measurements, there must be also added the triangle of coaptation of the aortic leaflets and the height of coaptation, similar to the case of the mitral valve. With the aortic regurgitation, the basal ring may appear displaced towards the left ventricular outflow tract, while with the aortic stenosis and retraction of the leaflets, the basal ring is displaced towards the aorta, or the basal ring cannot be properly defined. The best way of sizing the aorta and the left ventricular outflow tract is with a Hager probe during surgery. The basal ring can be enlarged through the fibrous portion by using the Nix and the Mainu-Guyan techniques, or through the muscular portion as in the Kono procedure. Another important landmark to evaluate the basal ring is represented by the aortic mitral hinge and opposite the most distal portion of the left ventricular outflow tract. At the level of the sinuses, the classical image of two sinuses actually refers to the sinus-to-sinus diameter, which does not cross the very center of the aortic root. In the latter case, the sinus-to-commissure diameter must be determined. These diameters are usually not equal to each other, depending also on the natural asymmetry of the sinuses and to their unequal dilation in disease. Consequently, all diameters must be thoroughly determined and compared to each other, especially when reimplantation of the aortic valve is contemplated. The diameter of the graft will be determined considering the diameter of the sinotubular junction and 2/3 of the double leaflet height. A particular case is represented by the bicuspid aortic valve, asymmetrical valve aperture and position of the coronary ostia. Again, the basal ring can be difficult to directly determine, while it is most useful to measure the diameter of the left ventricular outflow tract. Beside the presence of the raphe or calcification, the determination of leaflet pliability, it is also important to precisely determine the angle between the two commissures when contemplating aortic valve repair. This angle should be ideally more than 140 degrees. The various types of bicuspid aortic valve can present associated lesions, such as effacement of the sinuses, aneurysm of the ascending aorta, or a myxomatous mitral valve. Not least, coronary arterial variations are more frequent encountered in bicuspid aortic valve. For example, the high takeoff of the coronary arteries, especially the right coronary artery, or the left coronary arterial dominance. From all the details presented so far, it is evident that the valve-sparing operations must include the creation of neosinuses, the excision of all abdominal tissue or its securing to prosthetic material, while ensuring the triangle and the height of coaptation, and to restore the basal ring and the sinotubular junction. The well-known types of operations are the remodeling and the reimplantation, each with its advantages, limits, and particular indications. A David procedure is offered as an example hereby in these slides, with resuspension of the aortic valve and reimplantation of the coronary buttons. A few words regarding the ascending aorta aneurysm. It is worthwhile to consider additional elements in the clinical picture besides the diameter of the aorta. For example, the body surface area, age, sex, genetic background, thickness of the aortic wall, the shape of the aneurysm, and the rate and consequences of dilatation. Not least, the relative aortic size predicts better the risks of complication as compared to the absolute diameter of the aorta. However, in about 1/3 of individuals, dissection can develop on small diameter aortas, reflecting an increased tissue susceptibility to dissection. The advantages of the valve-sparing operations are evident and well known, with improved outcomes and results at 15 to 20 years comparable or even better over valve replacement techniques. The valve-sparing operations cross over from palliative to curative. The development of new types of prosthesis continues, while in some patients the Ross operation remains a good alternative. Evidently, there is no perfect repair technique, as no operation can recreate an anatomically perfect valve, but a functionally appropriate valvular complex. The aortic root has a more complex structural organization, and further research will undoubtedly endow the surgeon with new important details. Thank you for your attention.